Thank you, Dr. Kim. Again, very much welcome to this meeting. I'd like to start with some pictures taken during the previous meetings. The first 6-day symposium of this meeting in Minneapolis International Symposium was held in 1994 when Bob Anderson and Ventricular were together, and also Anton Becker was with us, and also at this particular meeting, Yu Shi-jun, the radiologist, coming this evening, and myself was invited to this meeting. It was very much honor because there was only selected person could join that meeting. The environment was very much similar like this. So almost 30 distinguished experts and 40 beginners or just starting cardiologists, cardiac surgeons, and so on. So in that meeting, we were very much impressed to start our first 3-day symposium on congenital heart disease pathology in 1995, just next year of this meeting. And then we started that meeting and having this meeting annually until now. And then we invited Bob Freedom on one time, and also Siu Yan Ho, and also Anderson was with us, and Becker was with us. We all invited during the previous meeting. I hope we appreciate very much the late Bob Freedom. And also we had and then we thought we can make an international 6-day symposium in Korea. That was in 1999. And in that meeting, again, Bob Freedom and what's his name? Japanese surgeon, Uemura, Dr. Uemura, and Bob Anderson played a trio as a special program of the 6-day symposium, and also we had a dinner cruise, and Anton Becker and what's his name? Czech. And famous cardiologist who joined the meeting, and we also visited to porcelain making factory to make this also. And then there's Kim Young-hwan over there, the group 2. He is teaching the colleagues in the previous meeting, and also Kim Jong-sun is here to having a session using heart specimen. And also we studied some special interest in conduction system, and we will discuss on Friday as a session. And also it's very nice to have very beautiful radiological 3-dimensional reconstruction. It's really, we don't need to have a real heart specimen anymore because of this technology. Anyway, but it is very nice to have this kind of pictures, and it was our paper showing some clinical pathological correlation of those things. And then we have, this is taken in 2 years ago, those Kim Sang-ho and Lee Chang-ha, and Song Si-chan is not yet here, and Kwak Jae-gon is also here. So most people are gathering annually usually in February, to take this opportunity sharing. So even though we are examining the same specimen, next year we are finding a new finding based on the same specimen. So by sharing our knowledge and experience is really fantastic to improve ourselves and improve partnership with different discipline doctors. The first slide is from in your book, and I'm sure I don't have to explain to you on this particular anatomy, but it's very clear to understand the proper orientation of a heart specimen. And as you can see, the frontal view of adult heart specimen is a little bit different from frontal view of heart specimen of the child. So as you can see, the size of pulmonary trunk is bigger in children, and the direction is different from adult to children. And also the location and size of left ventricle make some changes so that we can see easily from the front the children's left ventricle, but in adult is twisted a little bit more to have left ventricle behind the right ventricle. On the right side, we can see beautifully the superior caval vein and right atrium, and between the line junction between caval vein to right atrium is sulcus terminalis and terminal groove, and we can have a sinus node over here. And on the left side, we can see left atrium as a far most posterior structure of the heart, just in front of the esophagus, and also left atrium, left ventricle, pulmonary trunk going back to go to left side, left lung. And then the sectional view of the specimen is very much familiar for echocardiographer and the MRI and pictures, so that we have a left ventricular structure as a free wall and septum as a similar thickness, so that we can have a concentric contraction to make a high pressure from the left ventricle. In them there is a middle bridging anterior mitral leaflet, which is separating from inflow part of left ventricle to the outflow part of left ventricle. And there's an aorta having fibrous continuity with anterior mitral leaflet, and posterior mural leaflet is attached to the free wall of the left ventricle. On the right hand side, there is a septal leaflet attached to the septal surface, rather than having free midline structure of a septal leaflet of mitral valve. And also we can see anterior and posterior inferior leaflet of the tricuspid valve, which is far apart from the pulmonary valve. There is a muscular structure separating pulmonary trunk, pulmonary valve to tricuspid valve. We call it crista terminal, crista, what? Huh? No, crista terminalis. As crista supraventricularis, and or infundibular septum of vulvoventricular flange. Similar words are describing this structure. Outlet septum, something like that. And also from the in the other orientation, looking down from base to the apex, we can see beautifully left atrium as a posterior structure, whereas right ventricle is anterior and right structure, and there is a pulmonary trunk left anterior and aorta right anterior, right posterior, so that aorta is deeply wedged among these three valvular structure. And then the four-chamber views as a horizontal plane, in parallel plane to the diaphragm, we can see right atrium, tricuspid valve, ventricular septum, and left ventricle, right ventricle, and so on. And again, parasternal long axis view shows the right ventricular infundibulum cut in front of the aortic valve, and also the long axis of left ventricle means axis in the line from aortic valve to apex of left ventricle. And in this view, we can see anterior or septal leaflet of mitral valve in fibrous continuity with non-coronary cusp of aortic valve. And then from surgeon's view, the heart is turn 90 degree to have on the left side we have where's my cursor? Okay. On the left side, from cranial side, we have aorta and right atrium, and to my side, right lung is here, and in there we can see right pulmonary vein from my side to the heart side, which is looks like to the right atrium, but in fact there is a junction between right atrium to left atrium here, Waterston groove, so that the right pulmonary vein is going to the left atrium rather than going to the right atrium in this side. So this is superior caval vein, and pulmonary trunk is behind here, inferior caval vein, and so on. So I'm dissecting this Waterston groove so that we can separate atrial septum to two layers of right atrial layer and left atrial layer. Of course, this left atrial layer is in continuity to the right pulmonary vein, and then this dissection could go until the superior limbus of fossa ovalis. So flow of fossa ovalis is one layer, but limbus is a double layer structure having this right atrial structure and left atrial structure, and in between them there is a fat tissue, a little bit of fat tissue separating them, so that we can dissect and make more space to make a better approach to left atrium when we do mitral valve surgery. And then after dissection, we can see mitral valve like this. After we are cutting in this area so that we can see left atrium and mitral valve through this incision. And then from the right side, we haven't seen the inferior or posterior aspect of this heart, but in front of them there is a right ventricular pulmonary trunk and right atrium. Between them you see the aorta arising from the left ventricle, crossing right ventricular outflow tract. So that if we can dissect further down to aortic valve, we can have more space for aortic valve approach. And then there is a right coronary artery going there, and left coronary artery is to the left side of pulmonary trunk, so that is free from this area. And then after dissection, we can easily see the aortic valve. And then if we approach the VSD closure through right atrium, it is very easy to find membranous septum through right atriotomy. So in this case, we can see oval fossa here, and there is a coronary sinus, and septal leaflet and anterior tricuspid leaflet. We can see membranous septum, atrioventricular membranous septum, and septal leaflet, and underneath this septal leaflet, we can have a interventricular membranous septum. In this particular picture, we are putting fiber optic light, illuminating light through the aorta, so that we can illuminate the subaortic area of the heart, so that we can see membranous part of atrioventricular septum, and through tricuspid leaflet, and we can see membranous part of membranous septum. And also Tevesian valve and Eustachian valve is shown here, so that coronary sinus here and Tevesian valve is here, Eustachian valve is here. So Tevesian Eustachian commissure, we can define this area as a commissure between two rudimentary valve tissue of sinus venosus, and then from this particular point to the membranous septum, we can make a tendon of Todaro, yeah, tendon of Todaro, so that which is border to show the area for atrioventricular node. So I'm showing these kind of structures you are going to examine during the heart specimen section at the beginning. And also in this picture we can see this picture is taken the frontal aspect of the heart after opening the inferior inflow part of the right sided heart, so that right atrial roof is lifted off together with the right ventricular anterior wall is lifted off, So we see fossa ovalis and superior limbus, which has double layer in this structure. We can dissect from Tibet's Waterstone groove until this superior limbus, and then there is inferior limbus. This is eustachian valve, eustachian valve and Tibetan valve. So from here to membranous septum is tendon of Todaro, and AV node is here, and so on. And those areas attaching the tricuspid valve septal leaflet is so-called the inlet part of the right ventricular septum, and here is the trabecular septum and outlet septum in the as a division of right ventricular aspect of ventricular septum is over the papillary muscle of Lancelot or medial papillary muscle over here. So from the right ventriculotomy or pulmonary arteriotomy aspect of the right ventricle, we can see pulmonary valve is here and medial papillary muscle, and here is the membranous septum, which is intact in this specimen, and anterior, posterior, and septal leaflet of tricuspid valve has a variable morphology. And I have made some dissection of the musculature of the right-sided ventricular wall so that I can show what direction of cardiac muscle fiber is in this area. Here is the pulmonary valve. This is tricuspid septal leaflet, anterior leaflet, and posterior leaflet. So this is so-called crista supraventricularis or septal band, and so on. So as you can see, there is a direct fibers direct direction dividing in this area. So we some of those doctors like Jesse Edwards and those describe this as a bulba raphe. Raphe means attachment of two structure, which is this direction and that direction. So it was called bulba raphe or little groove in this area. And this is Dr. Van Pra said this is parietal band. This is septal band, which going through this trabecular septum marginalis. This septal band for Van Pra, and for Anderson only this part is septal band. This is parietal band. And also bulboventricular latch or bulboventricular flange is structure about here, so which is important describing term for double outlet right ventricle. So this is papillary muscle of Lancelot or medial papillary muscle. So after the removal of this surface muscular direction, we can see different direction, which is a part of left ventricular structure, so close to the left ventricular structure. So there is some interlacing direction of muscle fiber underneath our surface anatomy. So it's really interesting to speculate what kind of muscular structure, muscular direction is here, and through that understanding we can make a better treatment of surgery or some understanding of heart disease. And then again, this picture is taken from the frontal aspect of the heart after lifting anterior wall of right ventricle to the right side instead of lifting up in the previous slide. So we can clearly see three leaflet structure of tricuspid valve, but in fact it's not really three. We just say three leaflet because of the structure of papillary muscle. We understand the papillary muscle is a structure to making different leaflet approximate closely together. So because anterior papillary muscle, we can divide anterior and rest of the leaflet so that posterior inferior leaflet. Septal leaflet is rather constant to make a direct contact to septal surface of right ventricle. And on the left side, is we pathologists very often see the left ventricle, but surgeon says it's very difficult to see the left ventricle. Anyway, this structure shows right coronary cusp, non-coronary cusp, and usually in the heart specimen, the left coronary cusp is cut because of the the placement of the left side, so that to say pulmonary trunk, we cut the left coronary cusp. So, and then as we did but previously, we are illuminating to the to this area on the right atrium, so that we can see membranous septum, both atrioventricular and in the interventricular part of membranous septum together here, and there is illumination on the left atrium, so that mitral anterior leaflet is here. This dark area is interatrial septal area. Different aspects showing after removal of the posterior mural leaflet of mitral valve and free wall of left ventricle, we are looking at the septal surface of left ventricle and anterior mitral valve facing the aortic valve in situ, and there is a big anterior mitral leaflet and tall and wide anterior leaflet, which is different from the posterior mural leaflet of mitral valve, which is long and narrow. And this is anterior mitral leaflet. If we cut this valve, we can imagine there will be a fibrous continuity of this anterior mitral valve to non-coronary cusp of aortic valve. So now we are cutting this. Oh no, I didn't cut it. Sorry. But we just lifted up the anterior mitral valve, so that we can see left cusp, right cusp, non-coronary cusp, and non-coronary cusp, and part of left cusp is in continuity the anterior mitral leaflet. And here is the membranous septum, and I'm making some indicating the course of left bundle branch here. Again, the coronary artery is very important structure for adult cardiology, but also pediatric cardiology is also important structure. We have right coronary arteries going between the right atrium to right ventricle from right coronary cusp here, so that we can have an infundibular branch. And also we can barely see left anterior descending coronary artery. This particular specimen is also here in this room, so you can imagine this specimen, but now that specimen is a little bit destroyed and became old. After then we took this original picture almost 10 years, more than 10 years ago. So in this here, the left on the left coronary sinus, we have left anterior descending coronary artery, left circumflex coronary artery, and diagonal branches, first, second, third, and so on. And also the artery filled with darker resin is a coronary sinus, having this direction to make an opening in right atrium. And also in different viewpoint, right coronary artery going back to continuation to the posterior descending coronary artery, and also we can have here we can clearly see AV nodal artery at the very much on the Maria de la Cruz and Richard Van Pra and Bob Anderson for their contribution to systematic or sequential segmental approach on complex congenital heart disease. When I studied initially, I was fascinated to read the Maria de la Cruz's illustration and also Van Pra's diagrams, and finally Anderson's contribution to the better understanding of complex congenital heart disease. As you all understand, segmental analysis by Van Pra is a visceral atrial situs, which means visceral situs and atrial situs are going together. There are three types: solitus, inversus, and ambiguous. And ventricular loop is an embryological term to have the looping phenomena of ventricle make a D loop, L loop. And great arteries, there are solitus, inversus, D transposition, L transposition. we all understand now, but sometimes we find younger people not understanding what is D loop or L loop and D transposition, L transposition, and so on. So this is a very good understanding of complex congenital heart disease of Ventra explained. And also by Bob Anderson's sequential segmental analysis, he added two more structure connection. So atrial arrangement, ventricular relation, arterial relation. Between them, there are atrioventricular connection and ventricular arterial connections. So that we have 4 types of arrangement of atrial appendages: usual mirror images, right isomerism, left isomerism, and left-handed topology, right-handed topology. The difference is there's nothing different for topology and looping, but it's introduced because of the complex, some rare occasion, the location of the ventricle does not match to the real location of the ventricle. So they use the handed topology instead of looping. So arterial relation is the right anterior, left anterior, right posterior, left posterior aorta is described in as a relation. And then concordant, discordant, and absent and connections are described for those connections. By making these together, we can make a diagram, what kind of combination we can imagine, and also what structure, for example, this is normal heart from the atrial arrangement and ventricular loop together with the mitral and tricuspid valve location and relation of aortic valve and pulmonary trunk anteriorly. So this is normal heart, this is complete transposition, and these are very rare, so this is not considered as usual cases. And then as an inverse L-loop or discordant atrioventricular relation connection, we can have a mitral valve on the right side and tricuspid valve and right ventricle on the left side. So in this case, usually aorta pulmonary trunk are also transposed so that we can have a left anterior aorta, which we call L transposition, which is equivalent of corrective transposition. But in Anderson's explanation, is usual arrangement, left-hand ventricular topology, and L left anterior aorta. So finally, anatomical principle is going together with the developmental concept and clinical pathological experience. So we are having morphological basis. We have experienced very much clinical cases as well as human heart specimens, and developmental concept gave us very much understanding of complex heart disease, and clinical pathological experience is very much good to understand, and step-by-step analysis of each segment. And sometimes we face very common conditions, but rarely we have rare conditions. And we can make an hypothesis and prove so that we can explain easily, sometimes easily, but sometimes you can say this is not usual case, it's a rare occasion, and so on. So this is my summary, and then thank you very much.